Rajan, Rajanji, from the venue, Rajan San is there? Lotan there. Lotan sir, Rajan San. Lotan there is. Dr. Moriyama, good afternoon.
Yes, I'm here. Good
Oh,
afternoon,
nice.
everyone.
Nice to see you.
Nice to see you again.
Yeah. Our Lotan sir is also there. Namaste, Lotan sir.
Yes, namaste. I'm here.
Namaste. Yeah. So I would like to request you to co-chair from the venue. Both of you.
Me? Moriyama, right? Okay,
Yeah,
all right.
yeah.
Okay. I will
Moriyama
support
and
you.
Lotan.
Okay.
So I think we should start our program. This is 57th Apan Rural Healthcare session. So we have been conducting Kathmandu Model Hospital with FEC Nepal Public Health Concern Trust is organizing this session, is chairing this session from the last 10 years, I think. And most of the rural healthcare sessions have been very much successful. And we have learned a lot from this session. So today also there are good presenters, very renowned presenters who are going to present their experience on their research work. First, I would like to start with the introduction. Namaste all, I am from Kathmandu, Nepal. Dr. Uday Koirala. I am a surgeon by profession, and I also do work in rural health as well as in telemedicine. I also chair Telemedicine Society of Nepal. I am also in the member in the steering committee of this APA Medical Working Group. Thank you, all of you, for joining this. So I'd like to start with the presentation, with the introduction from venue. Will you please introduce? From venue, Dr. Moriyama.
Sorry. Okay. This is Moriyama from Apan Venue in Thailand. So thank you for joining us today. And I really appreciate all the chairs and all the presenters to organize this wonderful session. Through the pandemic, the internet situation was dramatically improved, especially in rural area. So now that we are ready to start many telemedicine connecting rural areas. This session should contribute to the future, brighter future for rural area. So we are much interested in the presentations. Thank you.
Thank you. Yeah, from venue, Lochon sir.
Hello, good afternoon. I'm Lochon Lalamate from Nepal Research and Education Network. Thank you.
I'm from Japan and from the KDDI as a private telecommunication company. I'm very interested in this field of the testing. Thank you.
So from the venue.
Yeah. Okay, thank you. Next, here we have friends in, now we are from Nepal Resource Education Network Hall, Conference Hall. And we have friends from ICT 4D, friends from Kirtipu Hospital, so they will be introducing them. Mr. Pawan.
Namaste all. My name is Pawan Sakya. I'm also the Vice President of Telemedicine Society of Nepal. Thank you and welcome you all.
Next, Abhimanyu.
Namaste, my name is Abhimanyu Pandey. I'm also from Telemedicine Society of Nepal. Thank you.
And Dr. Anu.
Namaste, I'm Anup Suvedi. I'm a physician, infectious diseases consultant at working at Kirtipur Hospital, which is in Kathmandu, which is also one of the hospitals managed by Public Health Concern Trust Nepal.
Hello, good morning, good afternoon. My name is Indira Sapkota, Nepal Telemedicine Society team.
Hello everyone, I'm Benita Damala from Nepal Research and Education Network. Introduction.
Hello, my name is Lakshman Bharathan from Mandarin. Thank you.
Okay, next, Nirajan, will you please introduce?
Hello everyone. I'm Nirajan Parajali. I'm from NREN. Thank you.
Dr. Chiara, we need your brief introduction.
Absolutely. Good afternoon. My name is Chiara Pittalis. I'm a health services and health system researcher from the Royal College of Surgeons in Ireland.
Thank you. And this time, your presentation will be much more awaited. Thank you, Dr. Chiara.
Thank you.
Just time.
Hi everyone, good afternoon. So hi, my name is Justin and I'm from the Ateneo de Manila University of the Philippines, Institute of Philippine Culture, and I currently work under Dr. Dennis Patangan in his digital health initiatives, digital health information initiatives and programs.
Thank you. Thank you. Patria.
Hi, good afternoon, everyone. I'm Patria Garcia. I'm also a research associate at the Institute of Philippine Culture at Ateneo de Manila University, same as with Justin over here. I also work mostly with digital health initiatives and research projects here in the Philippines. Nice to meet you all.
Yeah, thank you. From staff venue. Or from TEMDEC.
Hello. Hello. Enjoy the session. Hi.
Thank you. Dennis. Dr. Dennis.
Yeah, good afternoon, everyone. Yeah, I'm sorry, I am actually in another meeting. Congratulations to the host, and of course, thanks to our team, from Jazz and Pat, who's presenting for the Philippines. Good afternoon, everyone.
Thank you, Dr. Dennis. Sabina from KU, Kathmandu University.
Hello everyone, my name is Sabina Kesi. I am from Kathmandu University, currently enrolled at Masters in Health Informatics. Thank you.
Thank you. Michael Su. Michael. Michael, are you there?
Oh, yes, I'm in. Okay.
Yeah, please introduce yourself.
Hi, everybody. Good afternoon. My name is Michael Xu. I'm the founder of Cure Doctor Information Service Company. We do telemedicine and smart care, okay, in Taiwan. Today, later on, I will share my experience, okay, about how we do that, okay, for rural area. Okay, thank you.
Thank you, thank you. So now we are going for the first presentation. It will be done by Dr. Anup Suvedi. He's from Kirtipur Hospital. He's a specialist in infectious disease, and he's also head of department in medicine in Kirtipur Hospital, also the vice director of health academic affairs. So I'm handing over to him. So can you please share the screen now? Are the slides visible? Is the slide visible?
Yes.
Yes, okay. Namaste again. So this is Anup Suvedi. I have not had much experience about rural health, even though I live in Nepal. I was trained in the United States and I came back about 5-6 years back. I have worked very briefly in one of the remote areas near Mount Everest for about a year before this. And but I was here during the COVID pandemic, and I was one of the few infectious disease experts in the country, and therefore was very much aware of what was happening in rural areas and was very traumatized by the events. And so when Dr. Uday asked me to talk about communicable diseases in the setting of rural healthcare, and how we can use the SDGs to see if we can improve the situation, I thought I should share some of my experiences that I felt I gained in that COVID pandemic. Okay, so so I have nothing to disclose for this presentation. I will try to briefly assess the purpose.
Hello. 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 Hello.
Hello, can you hear us?
Yes, yes. It's presenters.
Yes.
too.
Sorry, we just got disconnected because the power outage, and so just connecting back.
Sorry for the interruption. Now is the presenter's mode, so that the
Sure.
please push the button. Yes, yes.
So
that's the one.
I will
swap
just
displays
try
on the
to
left.
basically. I'll try to just share my experience about how Nepal's rural area fared during COVID pandemic and what are the lessons that we can learn. So how did Nepal fare during the COVID pandemic? It can be, I'm sharing some news screen clips. Basically, there were very few tests.
So sorry for the interruption.
Available.
Sorry.
And then
sorry.
there was.
Excuse me. Sorry
Yeah.
for the interruption. Now we are watching the presenter's mode. So please switch the button. Swap displays on the laptop. Then we'll be able to change the screen to the normal mode. Swap displays on the laptop.
Recording in progress.
Swap displays here.
Okay.
Is that better?
Yes, now it's okay. Thank you.
Yeah, thank you. So there was virtually no public health infrastructure set up in the rural areas. But how do I? Okay. And then we had a situation where there were thousands of people having fever in different areas, and then none of them even able to get a test, and so a lot of people were just dying recognized by the government, system. I'm just showing you some clips, and then I mean, a proper way to do this evaluation would be going through, the WHO strategic preparedness and response plan, or some other way of, trying to identify different aspects of the public health response. But due to time constraint, what I'm just going to give you some like a brief snapshot. So, for example, third wave was over after the Omicron wave was, but there was still some going on. You see, we have 7 provinces in the country. In province 6 and 7, there were no tests on a particular day. On province 7, the second day, there were like 48 tests, and half of them were positive. So it's not that there were no cases, it's just that there were no cases at all. And in province 6, there was no case done at all on any of those days. And then, so there's a huge discrepancy. This just is an example of, the discrepancy we have faced. And these are the, most rural, most backward areas in the country. There have been studies looking at in a more proper framework, but in the interest of time, I'm going to skip. Basically, we had very limited access to masks, soaps, sanitizers. Even when there were quarantine centers, there was insufficient food and other resources. Testing was just too burdensome financially, had to walk for hours, or had to hire a vehicle which was not available to most of the people. And often there was just no test available anywhere. And regarding vaccines also, government did not run the vaccine campaigns in rural areas most of the time, just in urban district centers, they would happen. Or as documented for only those with power and connection. Or when there were vaccines available, they were the least effective vaccines that were available to rural areas. And then if you compare to another country like Rwanda, which is not a very rich country either, which is also a mountainous country like Nepal, Rwanda had, by 2020, halved the walk time to the nearest health facility from more than 95 minutes to 47 minutes by bringing more health posts closer to communities. They had already health workers at health posts that were providing essential care and making referrals when needed in a proper protocolized system. And then when COVID hit, their health posts were ready to help with the national COVID response effectively. And this is the commentary of the WHO that I'm quoting. And there were essential services were largely maintained during the pandemic in rural areas. And then there's further plan to reduce the walk time to the health facility to less than 25 minutes by adding more well-equipped and well-staffed health posts. So what's missing in rural Nepal? The reason I wanted to discuss this is when we talk about communicable diseases, the discourse revolves around vector control, sanitation, hand washing, soap, and mosquito nets, etc. But what the big elephants that we're missing are the public health system and primary care that have to be the backbone for any of these secondary public health interventions to actually materialize, be effective, and to be able to sustain the shocks of things like COVID pandemic. So in Nepal, public health is essentially just providing some vaccines to children, providing limited maternity and infant care, and some vertical projects such as vitamin A distribution, filariasis prevention, etc. But what's missing is this ability to surveillance, do outbreak surveillance, do test, trace, isolate, provide proper support to the communities in terms of knowledge, in terms of other resources when needed, and providing the right manpower. And this is resting too heavily on the shoulders of female community health volunteers. If you talk about primary care in Nepal, basically we have clinics that provide basic wound dressing, maternity care, basic maternity care, and they run the public health projects that I mentioned above. And most of this is provided by paramedics or by medical officers, who have just been out of medical school, who are unsupervised, and the care they provide, they are not really trained in like any of this disease management. And they don't have the protocols to support their clinical decisions. So and then when you talk about primary care in rural areas, in the government sector or in the policymaking sectors or in the INGOs, which kind of dictate the policies in the country. The question is, do they even deserve that kind of? That's the attitude. Do they even deserve that kind of primary care? That we consider for urban areas. So the primary care has received too limited investment in HR, diagnostics, other resources. And whenever the government has invested anything, it's more in the hardware, in the construction of health post buildings, or just buying some equipment like oxygen cylinders, or there have been situations where there have been ventilators in a health post which they can't use. So, I mentioned Rwanda, but we have similar lessons from countries like Vietnam, Sri Lanka, some Indian states like Kerala, Costa Rica, which have a robust primary healthcare system, and that primary healthcare system is working parallel with the public health system. And this is just a chart from Worldometers, and this can be done. Numbers can be misleading, but what you have to keep in mind is in Nepal we had very few tests, so we had very few deaths documented, and that's why our death number doesn't look too bad compared to, for example, Costa Rica. But our testing numbers is the lowest there, and so if you test less, you identify less deaths. And our excess death actually is more than 10 times the official number, according to studies by The Economist and some other agencies. So, and where do SDGs come here? So Sustainable Development Goals, they have several bullet points regarding healthcare in different areas, and some mention communicable diseases. So they also mention that one of the goal targets is achieving universal health coverage, including financial risk protection and access to safe, effective, quality and affordable essential medicines and vaccines for all, and access to quality essential healthcare services for all. And I think that's something we should remember. And then the other bullet point says strengthen the capacity of all countries, in particular developing countries, for early warning, risk reduction, and management of national and global health risks. So how do you, this is the concluding slide, basically. So if we're to achieve, make some improvement in communicable disease management in rural areas, it's not going to be just, vector control. It's not going to be just telemedicine or, some patch-up solutions. We need like a rural public health system that needs to be strengthened. We need a primary care system that is strong enough to, provide the backbone for all the other public health interventions and to sustain different shocks. And then you have to think about rural proof, national preparedness and response, and you have to leave space for localized planning and coordination, and also act on rural social determinants. Sorry, I think I went back. How do I go forward? Sorry. How do I go forward? Okay. Thank you for this opportunity. I'm sorry I went over time.
Thank you. Thank you, Dr. Anup, for the nice presentation. So I think we first move forward the next presentation, and then we'll have discussion on this in total. So next presenter is Dr. Chiara Pitalis. She will be presenting on technology-enhanced surgical supervision in rural Africa, lessons from Malawi, Zambia, and Tanzania. Dr. Chiara.
Thank you. Just one second. Can you see my presentation?
Yes.
Yeah, okay. First of all, I would like to say a big thank you to the organizers for inviting us to present at this important event. We're very glad to share our experience. And my presentation is about technology enhanced surgical supervision in rural Africa. Okay, so the work that we do is a direct answer to the call for action of the Lancet Commission on Global Surgery. The Commission in 2015 estimated that 5 billion people across the world lack access to essential surgical care. And Sub-Saharan Africa is one of the regions with the biggest gaps. So most of our work is with partners in Africa. Just to give you some background, in Sub-Saharan Africa, in many countries, a large share of the population is based in rural areas. And the first point of entry into the surgical system for rural population is usually the district hospital. Those are smaller hospitals that are either in rural areas or small villages, so quite small facilities. And often there are no surgical specialists at all in district hospitals. The bulk of work there is provided by non-specialists. Those could be either general medical officers or non-physician clinicians. And often they practice in resource-constrained settings, unsupervised and with very limited support. So when we started our work back in 2017, there was a need to investigate ways to better support rural clinicians and at the district hospitals. This is the basis from which we developed the Surge Africa project. As I said, we started in 2017 thanks to the support from the European Union. And we work with partners from 3 European countries and 3 African countries. And within Malawi, Tanzania, and Zambia, we also partnered with the local ministries of health, professional associations, training bodies, medical training bodies, and many hospitals. And in a nutshell, our intervention had 2 elements. First of all, we established a system of regular supervisory visit by surgical specialists from the central hospitals, from the big cities, to clinicians at district level hospitals. And during the visits, the supervisors provided on-the-job training, advice, and mentoring to the local clinicians to build their confidence in providing essential surgical care and also for quality control. And this was complemented by a managed consultation network. So a remote consultation network to allow coordination between supervisors and the district clinicians in between visits, and also to allow them to consult if there was any emergency case or any difficult case in between the visits. So overall, the goal of this intervention was to strengthen the capacity of the local surgical system to deliver essential surgical care to rural areas that are usually underserved. We tested these in 31 hospitals across the 3 countries, and we used a mixed method control design. And for the sake of time, I'm not going to go into details, but everything has been published. So if you wish to find out more, you can read our articles. I just want to spend a couple of minutes to talk to you about the experience of Malawi, the example of Malawi, to show you what the intervention looked like in practice. So Malawi is one of the poorest countries in the world. I think at the moment is the 3rd poorest country in the world. It has quite a large population, about 18 million, mostly based in rural areas. So it's a very rural country. And it is estimated that 1/3 of the population lives with a condition that might require surgery. And lack of access to surgical care is also a major cause of deaths. About 24% of all deaths are due to surgical condition. And like I said before, in rural areas, care is usually provided by district hospitals. In Malawi, there are about 24 of them, and they're mostly staffed by a type of non-physician clinician called clinical officers. There are no surgical specialists at all in Malawi in rural areas, just clinical officers. And when we started working in Malawi, the clinical officers used to work in isolation, And they tried to do what they could to manage surgical cases that presented at their hospitals. But whenever they couldn't handle the case locally, they would just refer to the central hospital. And there was not much coordination at the time between district and central hospitals. Communication was poor, and many referrals were actually unnecessary. They could have been handled locally if the clinicians were supported in a better way. So this is the scenario from our intervention. As I said, we established a regular program of supervisory visits, and we also set up a consultation network. And I'm going to focus in particular on the second part, the consultation network. Sorry, So the aim was to facilitate real-time access to expert surgical advice when needed, to streamline surgical referrals, and to provide a space for exchange of medical knowledge and for capacity building as well. In practice, we use WhatsApp. The reason we chose WhatsApp was because it was already available in the country. Most clinicians have it on their phone and they use it for family, for private, but also for work-related purposes. So they are very familiar on how to use it. There was also the benefit that in Malawi, when you buy credit for your phone, WhatsApp is free. It's already included in the package. So there was no extra cost for the participants. And it's also well encrypted, so security-wise, it's quite good as a platform. But as an extra measure, we also partnered with the Ministry of Health to develop an ethical code of practice to ensure that patient confidentiality would be respected and also to avoid inappropriate behaviors. And at the very start, we had a dedicated person to manage the network. But after a few months, once the rule of the games were well known to everyone and the network started working well, this person stepped down gradually and the network continued to work on its own. So the images you see here are just two examples of what type of communication happened on the network. So the image on the left, this is a clinician from a district hospital in Mulanje consulting about a case that he was faced with at the time. It was a child. So he posted his questions on the group, and then a specialist surgeon from the central hospital within just 2 minutes answered and provided advice. So it's quite fast. And the other two messages that you see below, those are other clinicians that are witnessing the communication and they're learning from it. So one benefit of having this network is that instead of having a communication between just two people, the whole community can witness communications and consultations and can learn from it. At the very start, we had over 100 clinicians in the network. Now we have many more. So it's really a good forum for people to learn from each other and to share advice. On the other side, on the right side of the screen, this is another case that was consulted. It happened to be a child again. And you can see that actually not one, but two surgeons, specialists answered. So that's another benefit of the network, that before, the clinicians at district level had very little chance of getting expert advice from the central hospital, but through this network, they can access a variety of specialties. So it's very beneficial for them. In this particular case, as you can see, the advice was that the patient was too critical and it was better not to refer because chances of survival were very poor, and that it would be better to just consult the family and handle the patient locally. And I want to highlight this because of the socioeconomic situation in Malawi. Many families in rural areas are very poor. So for them to travel to the city is a huge burden. Economically, emotionally, transport is also very difficult. So avoiding unnecessary travel to the big city, it's really a big thing for them because sometimes they could incur catastrophic expenditure. And it's also beneficial for the hospitals because if they're not able to cure the patient, if the patient dies on the way, there would not be a good use of public health resources, despite this being obviously a very sad case. But it's just an example of the improvements that were made to the health sector. So we, apart from the images that I showed you, we also evaluated the network rigorously at the very first few months before scaling up. So between April and July 2018, we analyzed 95 cases that were posted on the network. And the highlights of our evaluations are that unnecessary referrals were reduced by 30%. So as I said, this is a huge change compared to what was the situation before. There were also improvements in the quality of case management and access to a wide variety of expert advice from the central hospital. In 75% of cases, the management decision was reached in less than 1 hour. So it's pretty fast compared to what happened before. And since 2018, when we started this work, the platform is now part of standard practice in Malawi, and every single case that is referred from the district has to be posted on the network. So this is a huge improvement in terms of coordination and communication and also quality of care. And as I say, there are major benefits for both the families and the hospitals involved. So in conclusion, we found that the model in Malawi was very successful. It can offer a sustainable solution to improve access to care for rural populations. So decreasing unnecessary referrals, bringing surgery closer to local communities, and also improving quality of care. And actually, it was so successful that after the end of the project, we managed to secure funding for a follow-up initiative called KidSurge. So it's the same model, but focused on pediatric care, pediatric surgical care. And I think there is great potential for application of this model in other surgical subspecialties, but also in other regions or countries with similar settings. So for the sake of time, I'm gonna close my presentation with this, and I'm very happy to take questions afterwards if you wish to find out more. I just want to say thank you again. Here are my contact details if you wish to continue the conversation. And I also want to say my presentation was about Africa, but actually RCSI, my university, has a campus in Malaysia. So we have operations in Asia as well. I will be traveling to the Philippines myself at the end of February. My colleagues will be in India in March. So there are opportunities to continue this conversation beyond this meeting. And thank you so much for your attention.
Yes, thank you. Thank you, Dr. Chair. So being a surgeon, I was very much interested with your presentation. First, we'll continue with next presentation, and then we'll have a discussion. Next will be Michael Su presenting on preventive healthcare in rural area. Michael, please.
Yes, thank you. Let me share the slide first, okay. I'm wondering if you can see it.
Yes.
Yes.
Okay, thank you. Okay, good afternoon, everyone. It's my honor to have the opportunity to share my experience about how we use digital technology in the eco-partners architecture to improve the quality of healthcare in rural area. There are 4 problems. Okay, 5 problems we want to deal with. Okay, first is high transportation time and the cost to see a doctor in rural area. Second is the delayed medical care create great medical and social cost. Third is the detecting disease too late, mainly due to no inspection or insufficient medical knowledge. Number 4 is the local government lacks a people-centered digital platform. The next one is inspection data are scattered in individual institutions. So because this service involve a few stakeholders, so we want to use eco-partners architecture. Okay, firstly, we work with the government to let government to take the lead, organize it, and government will connect the clinics and the care center and the service people, okay, forwards. And the NPO, Wise Love, will coordinate all the services, and Cure Doctor our platform will provide the smart care platform for this service. And we let enterprise pay for it as their CSR. So everybody, eventually, everybody can win because government has no need to arrange budget. Government enterprise pay for it. And all the other stakeholders can fulfill their job, okay, in the mission, okay, seamlessly, okay. To deal with our problem, okay, we provide a solution, a comprehensive solution, which is sustainable. First, you can see in the center,
Excuse me.
it is a health cloud.
Excuse me. Could
Yeah,
you
yeah,
slide show, please?
yes. I beg your pardon?
No, start slide show.
Oh, slide stop. Okay, can
Slide show.
yeah, let me do it again. Okay. How to do slide? Okay. Can you see it now?
Yes, but not it. It is not slideshow. Can you see the bottom of
Right bottom, you'll be able to find out the slideshow button.
Slideshow button, okay.
Yeah, right bottom, just close. Yes, that's
Right
that
there,
one,
yes.
right?
Okay.
Yes, good, perfect.
And
Thank
please
you.
turn
Okay.
on your face.
Okay.
Turn on your
Good.
camera.
So you can see in the center, it is a health cloud, okay, which comply to GDPR and also certified with ISO 27001. And we provide 4 services. The number one is preventive care. Okay, later on I will make further introduction. The second one is health education. The third one is physical examination. The fourth one is telemedicine. So all the service is a together total solution for the rural area. And here are some devices we provide for the rural area in the care center for their daily preventive care. Okay. And here is the process, okay? The first is the caregiver measure for those elders and upload those data automatically. And once there are some abnormal data, okay, then the system will provide the notification to the specified designated, okay, nurse and their family member, okay. Why it doesn't move now? Okay. Okay, the third is you can see the nurse can see can get the abnormal message, okay, notification, and the system will provide a telecare job card, okay, for her, okay, to make a call to care the elders. Number 5 is the nurse can arrange a video call or make an appointment with the doctor in clinic, okay. Then, if necessary, he can transfer the the patient, okay, to the hospital. The local government health bureau can manage the whole system and get all the report. And the enterprise who donate the funding can also get the service report for their CSR, okay, which is without personal data inside. And here's how we do it. And besides the daily care, we also work with the public clinic, okay, to provide physical examination, which is with AI aided. For example, the 12-lead ECG, okay, sleep monitoring, and also TB bone density AI inspection. In this slide, you can see, okay, I'm sorry that, okay, it is in Chinese, but just to show you that, okay, the AI can show to the patient and the nurse and doctor and about the risk in 1 year for the patient about the stroke, AF, okay, heart failure, etc., and also can show the risk level of heart function. This is a sleep monitor AI report, and here also show you, okay, how many times the SpO2 drops, okay, and how many times, okay, it's less than 90%. And this slide shows the local government or the NPO or the enterprise. Everybody can get their report, okay, which with all the service number and the service record, and so that they can provide verifiable data and to do the to measure their impact and value. Yeah. Okay. This is all. Thank you for listening, and I'm looking forward further discussion with you if you are interested in working with us in the future. Okay, thank you.
Thank you, Michael. It was really very nice presentation. So we'll move to next presentation. Dr. Patria and Justin will combinedly presenting on leaving no one behind, the ETSI Novus project. Dr. Patria, please.
Hi everyone. Good afternoon. Can you make me co-host? Sorry, I got disconnected a while ago.
Oh, really? Co-host.
Yeah. Okay. Thank you. So I can share my screen on my end. Can everyone see my slides already?
Yes. Yes.
Okay. Thank you. So good afternoon, everyone. My name is Justin Calderon, and I'm part of the Etsynovus project led by Dr. Dennis Batangan, and also with us is also Dr. Enrique Nino Pileviste and Patria Garcia, as well as Ms. Liz Bautista from the British Embassy Manila. So this project is currently funded by the Foreign Commonwealth Development Office of the UK, and also being implemented by the Ateneo de Manila University and Institute of Philippine Culture. So to begin, just a quick background. In the Philippines, local governments are responsible for delivering essential health services and social services as well. A crucial objective of these governmental bodies, such as these local governments, is to ensure that individuals who are both eligible and in dire need of health or social services can effectively avail of these services. So despite the overarching goal of mandate of the government institutions, both local and national, the practical implementation of the delivery of health and social services are barred by a range of challenges, which includes siloed health information systems, incomplete databases and registries, incompatible information systems, difficulties in identity verification, which overall contributes to individuals being unable to access the necessary health and social services. And regrettably, the most affected of these issues belongs to the marginalized and or vulnerable groups, which includes indigenous people, informal settlers, senior citizens, persons with disabilities, and street dwellers. Slide. And so the project commitment is anchored on the core principle of leave no one behind. It is a fundamental value of sustainable development goals. With this, we are dedicated to exploring the transformative capabilities of digital technology, with a special emphasis on data analysis. So the overarching goal or the main North Star of this project is to create a robust health information system that not only streamlines and enhances data accessibility, but also serves as a catalyst for evidence-based decision making. By achieving this, the pilot this project seeks to pave the way for enhanced efficiency in health service delivery through improving health information systems and better serving the most vulnerable populations. So currently, our project is being implemented in Pasig City, Philippines. So Pasig City is a highly urbanized city located in the Philippines, Metro Manila. It represents 5.96% of the region's population, and it has a 30 barangays or smaller districts within the city. So universal healthcare available to every Pasigueño continues to be one of the city's priority trusts. So the city government puts premium on its constituents' health and well-being currently. Currently, the priority is on the full implementation of the universal healthcare in Pasig City. Since Philippines recently passed a law on the implementation of universal healthcare just before COVID started. So in the conception of this pilot, the British Embassy Manila, through the Better Health Program, has previously worked with Pasig City in developing and setting up a digital patient registry and a health information system. This system was designed to support healthcare workers in effectively managing patient health records and utilize data to enhance the quality of patient care and service delivery under the non-communicable disease program of Pasig City. In the context of this project, the team sought to build upon this existing work. So the goal was to leverage the foundation built by the Better Health Program, the system that they built before, which presents a wealth of data readily available in the registries, to develop a specialized tool. So specifically, the pilot sought to develop a tool to help those responsible for managing health or social programs in identifying vulnerable individuals who could benefit from targeted support to access specific services or benefits in terms of health. And then this tool that they have previously developed that we're currently developing is the multi-program local mapping tool, or the MUPLUM system, which is an national non-communicable disease reporting tool. So basically, it has efficient NCD. It helped the Pasig City in efficient NCD recording and reporting. So it has an electronic application for streamlined recording and reporting of NCD cases such as hypertension, diabetes, and it is also tailored for local government. It is specifically designed to support NCD programs within the local government setting. And it also have a comprehensive disease registries, which enables the creation of maintenance of disease registries for selected NCD programs. So right now, later you will see the current disease registries that are currently in the system of the MUPLUM system. So next, other features of the MUPLUM system is the real-time notification features. It incorporates notification features to facilitate prompt response and actions. Also, it is user-friendly. It has a user-friendly interface, intuitive design for easier navigation and user-friendly experience for our healthcare workers and data encoders in their own respective health facilities. It also enhances public health management. This is a tool aimed at improving overall public health outcomes by strengthening the NCD management at the local level. So currently, this is the sample dashboard of the MUPLUM system. The disease registries formats and reporting schedules are defined by DOH and the DOH 2018 Field Health Service Information System Manual Procedure. So basically, we pattern this to the national mandate from the Department of Health. And then as of late last year, late 2023, we already have 105 patients in the registry compared to the overall population of Pasig, which is around 800,000. So we're on the 100,000 on our new plum system. So yeah. So here you can see now the current path or phase of the Etsinobus project, which is the enhancement of the new plum system. So what we did is we at first we had the programs and systems review together with the City Health Department of Pasig City and also their healthcare workers, those who are the end users of the system. And then we had a systems design and joint application design, and then we developed the prototype for the enhancement, and currently we are now on sprint 3 on the adoption and utilization for the selected Etsinobus use cases. So we already implemented this with our pilot sites. So Patria will discuss this later. And later on, after our implementation and adoption phase, we will turn it over to Pasig City and also conduct a sustainability plan for it to continue without the support of the project. So maybe I can this is the part of Patria, the situational analysis that we did for the project.
Thanks, Jazz. So just quickly building on what Jazz has already discussed regarding the project, we simply wanted to expand more on the MUPLOM system, as Jazz has mentioned earlier. But since our organization, the Institute of Philippine Culture, anchors itself on using or implementing participatory action research, we decided to do the methodology of conducting a situational analysis with Pasig City. So this helped us to properly identify the gaps in the needs of the city. This was conducted by the research team of the Ateneo de Manila University. So we started this off with consultation meetings with office heads, specifically the City Health Department key personnel. And then we follow this up with key informant interviews with select health facilities staff. Participants were asked about the work that they do, what they think they can do better to reach out to vulnerable populations within the city, thus then appropriately providing them with the necessary health and social benefits and programs already available within the city. Sorry, just next slide, please. So through that situational analysis that we conducted, we were able to identify 2 major features that we can build on and develop for 2 sprints, as mentioned earlier. So one of these was the loss to follow-up feature for NCD patients, which basically essentially tracks when the last consultation or risk assessment was done for a particular patient who might be at risk for any NCD case. And then the other major feature development that we did was the validation of the National Household Targeting System, Poverty Reduction, or the NHTSPR program being conducted nationally in the Philippines. So this would essentially make the process quicker for health facility staff to identify who are under this list. This is essentially the poorest of the poor list of the Philippines. Next slide, please. So this is how it looks like. So this part here being highlighted by Justine gives the health facility staff an idea which particular patient should be followed up or is not being followed up for the past 3, 6, 9, or 1 year. And then if a patient reaches a particular threshold for set by the Department of Health in the Philippines, so that patient will also be tagged as needing or requiring another NCD risk assessment for that specific year. Next slide. So currently, the project is in its utilization and implementation phase, as mentioned by Justine earlier. The 2 major developed features have been rolled out to most health facilities in the city by now. We just had our training sessions last week and last December. So it's currently being utilized to hopefully better aid health workers in the city in identifying and prioritizing vulnerable populations. Next slide. Just to situate the rural healthcare in the Sustainable Development Goals. So the system itself assists Pasig City in, first and foremost, health infrastructure planning. And we would like to elaborate on this further in the coming months with Pasig City, since this will develop new healthcare infrastructure based on available data and identified gaps and needs within the city. Secondly, the system also assists the city in disease surveillance and response. It implements real-time disease surveillance to monitor the prevalence of diseases and outbreaks. Third is community health education. We also wish to explore this further with Pasig City to basically tap into their community health education unit, which will essentially use the mapping tools available within the system to help them visualize health education programs and identify areas where community awareness and education may be lacking. So to implement, we would like to implement this to target health education campaigns based on mapped actual data of the city. Next slide, please. And the last two, the system also assists Pasig City to collaborate and to better coordinate within the city. It streamlines their efforts to avoid duplication and to also ensure efficient use of resources such as medicine being dispensed. And lastly, the goal of the project, which is reaching to vulnerable populations within the city. So the system aids the healthcare workers of the city to expedite the outreach activities to vulnerable populations, facilitating swift access to essential health services, health and social services. Next slide, Jess. And then for more information, we actually have a blog post available. You can use the QR code on this slide or use the link featured in this on this slide to further read more on how we got into the development of the system in the past few sprints and in the past year, and then how it actually came about during the previous program that it was under. Next slide, Jess. If you wish to further the conversation, we would be very happy to reach out and discuss more about this. These are our email addresses, Doc Dennis's, Jazz's, and I. Thank you very much.
Thank you, Dr. Patria and Justin. It was a very nice presentation. So now we have one more presentation. Sanjay Paudel is going to present. Sanjay, are you there? Sanjay?
Hey, sir. Sorry. Hey, can you hear me?
Yeah.
Just a second. Just trying to share my screen.
Yes.
Yes, sir. Can you allow me to the other screen? I just sent the request.
I think now you can share.
Lisa, could you please allow me to share my screen?
Yeah, you already watched from Sanjay.
Please share, sir.
Okay.
Yes.
Yes.
Is my screen visible?
Yes. Yes.
Okay.
Please continue.
Thank you, Desa and the team for providing me this golden opportunity to share and also the update about the interoperability in Nepal and the initiatives from the government, which has recently been as the initiatives from Ministry of Health of Nepal and through the support of GIG. So basically, standard interoperability lab is something that we've been getting support from AHIN and SIL Thailand, and the modality that what we are trying to do in Nepal is to make all the software ecosystem into the one platform within the government and make them interoperable to each other, which means like the way the digital health system currently being used in Nepal are fragmented and our silos are not being able to communicate to each other. So in order to facilitate the problem within the digital ecosystem being fragmented, this lab will capacitate the healthcare technology developers as well as the healthcare infrastructure to communicate to each other in the standard way. So what is SIL? It's basically the platform, it's the process to make the system interoperable from the framework being developed by Ministry of Health, which also helps to ensure communication between the multiple platforms as the source of the data are from the community, from the hospital, and also from the telecommunication medicine, telecommunication and all. So telemedicine and all. So the way the modality will be, it will ensure compatibility between the system and also a smooth communication within the department as well as with the hospitals. It is much vital, acts as a pivotal to join with the diverse of technologies and also risks the issues of the incompatibility between the different platforms. So the approach of the lab will be teaming, training, tooling, and testing. So the since we are in the very early stage, the approach is T4, wherein we will be closely working with the multiple IT developer, health IT application developers. We'll train them. We will finalize the tools that's already been used in the open source community, and also will facilitate the healthcare applications to test their application within the Ministry of Health and deploy to the healthcare facility as well as the point of services. So right now, the approach of the infrastructure lab setup is to create the testing environment, create the robust network infrastructure, virtualize and simulate the tools, and also enable the developers and enhance the fragmented system or support the fragmented system to come to the standard approach that is FHIR and then communicate with the national health system. So currently we have finalized the ecosystem of OpenHI, where we will follow the open source ecosystem itself and the different registries. There are multiple registries right now. We enable them to connect with the national registries and also come under the OpenHI architecture. In terms of the interoperable part, FHIR will be the de facto standards that we will be following, and also from the point of service ecosystem, the testing modules will come up from the OpenMRS/BAMNI, because most few of the hospitals in Nepal, almost 25 different district hospitals are using the OpenMRS ecosystem, and which makes the sense that all of the open source ecosystem are using the OpenMRS. So this is the proposed reference architecture, which is the de facto open source model endorsed by the OpenHI community, wherein interoperable layer, business layer, and also the registries will be communicating to each other, and also follow the same architecture within the health IT infrastructure. We believe this will create the further opportunities to work together. Right now, we are working with Telemedicine Society, ICT4D, and also this will open the collaboration platform for the international communities ecosystem, wherein we will also get the opportunity to work, and it will also create the opportunity to collaborate within the multiple countries ecosystem. So this much for now. I think the approach of SEAL is to enhance the developers, train the developers, train the users, hospitals, and enable all of the underlying ecosystem users as well as the trainers to come up with the OpenHIE or SEAL Nepal ecosystem. So if there are any other questions, please feel free to add on. Thank you.
Thank you, Sanjay. Will you please stop the sharing?
Sure, sir.
Yeah, thank you. So yeah, it was very timely and nice presentation. Now I would like to start the discussion, because when I selected this topic, without improvement in rural healthcare, this whatever we say, health for all or universal healthcare, or sustainable development goals, health, quality health to the last citizen of the universe, whatever you say. So without improving the rural healthcare and without applying the technology to the rural healthcare, we are not going to achieve that goal. So everyone, we can see that everyone is working from their own and from different aspects. They are trying to make it happen, and all are working so efficiently. And what we want to do is we want to learn from each other's experience, and we want to customize that to our own need and apply that in our own periphery. So thank you all. Now I would like to open the floor for discussion. And if you have any queries, first I would like to start with Dr. Anu. So if you have any queries regarding this communicable disease and the sustainable development goal regarding communicable disease, so the floor is open. Is there any question or comment? From the venue?
Dr. Koirala, if I may.
Yes, Dr. Kiara, yes.
I have a comment more than a question. I just wanted to say thank you for this event. All the presentations were very interesting and different. From my perspective, it's good to learn about what is happening in different countries and from different perspectives. But it's interesting to see also that there are many commonalities. I was just listening to the other speakers, and I see a lot of things in common with what we do. For example, the focus on frontline services. In widening access, universal access to services, the role of frontline services is very important. The public health dimension is also something that seemed to come up. And then the attention to vulnerable groups, which whether they are in urban or rural areas, is also a priority in this conversation. So yes, I just wanted to comment on the commonalities as well.
Yeah. Yeah, thank you. And another thing is I was very much surprised to see this surgical supervision, because we are also doing supervision to different rural hospitals here. And sometimes the surgeons there, general practitioners, they call in the midnight and say, okay, I'm exploring the abdomen and I couldn't find appendix. So, so they'll show me the camera and I would ask them how to look for the appendix. So those things are very interesting, and Okay, there are someone who are also thinking like me. So I was very much interested in your presentation. So I think you are most welcome to Nepal as well, and we are very much enthusiastic to have collaboration with you.
Thank you. Thank you so much.
And yes, next is Michael Su. We have been communicating with Michael Su from Taiwan. So you have a very good system there. And I'm always thinking, how can we customize that into our own need? So Michael Su, have you ever thought about that customizing in the country like Nepal, your system? Michael Su, are you there?
My microphone is off. Okay, again. Okay, sorry. Okay. Of course, okay. Well, we are very eager, okay, to looking for partners, okay, in everywhere, okay, not only in Taiwan. 7 years ago, when I founded White Love NPO, okay, our mission, okay, is to provide a better healthcare, okay, to those vulnerable people, especially with the digital technology. And we are right now keep on optimize our system, okay, and adapt AI to do the aid and the support, okay, to improve the quality. And if any customization required, okay, and we were okay very happy, okay, to explore that possibility as we can, okay.
Yeah, thank you, Michael. So from the venue, is there any question, comment, or suggestion? Yeah.
This is Dr. Moriaba from venue, EPAM venue, and I've got one question also to the Dr. Shu. To take care of the patient in rural areas, your devices such as a remote blood pressure test or something like that, temperature testing or something, they should be delivered to there. So in not in urban area, it is quite easy to provide this equipment to the patient's home. But how to take these devices to the patient in rural areas? Do you have any ideas on that?
Yes, we work with local government. Okay, firstly, we select the daycare center. So for each daycare center, usually they have around 30 elders people inside there, and they have caregivers. Okay, usually 2 caregivers. So infrastructure is over there already. They have bandwidth, they have a computer. Okay, so we just provide a set of the IoT device, okay, to the daycare center. And then the government will ask those caregiver because they pay them, okay. So their job, including, okay, to do the measurement for those elders, okay, every day. Okay, that's how we do. And for some people, they are at home. Okay, we work with clinics and hospitals. They have okay, their nurses. They will patrol, okay, to those home. Okay, not every day. At least every other day they will go there, and they will bring those devices with them also, so they can do the measurement and to do some prevention. For example, we work with a major hospital, okay, in Taiwan. Their nurse go to a home, found an elder, okay, the blood pressure is very low, down to 50 something, okay, and then by coordinate with the emergency doctor through video consultation, they decide use ambulance to deliver the patient to the hospital and found out, okay, that patient does have some serious problem, and so that they can give her, okay, actually a woman, okay, the medical service, okay, immediately in time. Thank you.
Thank you. Building up the small centers in each district is important under the collaboration with small local government is important, right?
Yes.
Thank you so much.
Thank you. I would like to know from Dr. Patria and Justin, so how do you do this community awareness about the digital health? Because here we are facing a lot of problem from the healthcare are not very much to apply this digital health, and even the record data keeping is being very difficult. So is there anything that you do? How do you collect the data?
Hi, good afternoon. To answer your question, actually the overall approach to the project that we have been doing is from our learnings on different implementation that we have done from the past with rural health facilities in other provinces in the Philippines. So basically, with the current with the passage of the universal healthcare, which entail the use of electronic health information systems. So right now, every province or implement universal health UHC universal healthcare access advanced implementers are currently uh, 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 implementing and engaging with different electronic health information systems providers. So what we do is to create a system that can connect to that can connect and harmonize with the different electronic health information that is being used and currently being used in other provinces, cities, since most of them have multiple health information systems. And also we do capacity building and trainings to our to health workers in our health facilities so that they are well equipped in handling the different health information that they are currently gathering inside the facility. So we do not just implement and give them the technology, but we also have a capacity building counterpart where we explore with them and train with them on how to use this current uh, health information systems. Yeah, maybe add on that.
I have a follow-up question if that's possible. Is that so? To the Philippines team, I was just wondering if your medical programs or nursing programs or paramedic programs, if there are any health informatics courses which are mandatory. And as an analogy, what I say, if you are studying radiology, obviously you're going to hit an ultrasound machine, an X-ray machine, and so on and so forth. So why not have a course like that? At least in Nepal, that's what I have been saying. But I'm just wondering if that happens in the Philippines on a regular basis from like the first semester onwards.
Yeah, thank you so much for that. Actually, we Dr. Dennis Batangan is also currently working on that, and our project team also created one. I don't know if this is the first but it's a partnership with the University of the Philippines, the Department of Computer Science, where it's focused on digital health information technologies. So,
Okay.
but on medical field, I do not know if there are required courses for digital health interventions and information systems. Yeah.
Thank you.
Thank you. Thank you. And my last question to Dr. Chiara. So you do this supervision from such a remote. What are the suggestions or what are the feelings of the local surgeons? Because sometimes when the senior surgeons from remote are connected with do they connect directly to the patients there as well, or only healthcare workers to healthcare workers? And how do they feel? So, sometimes they may feel embarrassed, like because someone senior is connected and your work is being supervised, so you can't do some which is not in the guideline, or like, is there such feedbacks?
Yes, thank you. Indeed, there was an issue at the start. The clinicians at the district level were a little bit reluctant to expose themselves in the forum where everyone could witness what they're doing. But that's the beauty actually of this forum, is that it removed barriers between the specialists and the non-specialists, because after a few months, after a few trials and errors, they started trusting each other more and being more confident. As I was showing in my presentation, other clinicians were also learning, and so bit by bit started inputting in the forum. So yeah, it takes some time to adjust, but it works well, because maybe also the fact that everyone is on the same boat, that everyone is facing the same challenges helps, because then the clinicians are less scared of making comments. From the supervisor's perspective, one issue was that at the start, they found it a bit overwhelming to get all these messages and all these requests for help. So they had to organize themselves and ensure that one person would be maybe monitoring the forum at a certain time, and then another person at another time. So again, it took a little bit of time to adjust. But once they worked out the system, it was very helpful. And lastly, one big change that was helpful for the supervisors is that, as I said, one issue that there was in Malawi at the start is that the district used to send patients all the time without telling the central hospital in advance. So the hospital at the central level was not ready. They would receive all those patients at the same time without warning. They wouldn't know, they weren't ready. So having this communication in advance allowed also the supervisors to do their work, to organize their work better. So yeah, there were good relationships established.
Thank you. Thank you. So is there any additional comment?
One comment to Dr. Chiara. I think that's a great system that you have, and especially the WhatsApp. Generally, I try to keep away from WhatsApp, but I think this is one of the first times I think I'm a convert. I just had a question regarding how do you manage, like, a couple of patients, maybe a couple of hundred, maybe even might be okay, but when you get into the thousands, and patient history and patient follow-up and patient analysis, WhatsApp becomes a bit cumbersome. Is there a separate patient recording system as well in parallel?
No, in reality, no, because the system is still, the data entry system in Malawi is still paper-based. There are no digital registries of referrals. So for now, this is the main system. From the point of view of the burden of work, as I said, the forum allows an element of learning. So at the very start, there were a lot of requests about the same cases, the same questions. But after a while, the clinicians are learning, so they're asking less of the same questions. So over time, that helps. We also train the district clinicians on effective communication. So we give them a manual about when they want to ask a question, what are the essential elements, essential data that they need to communicate. Because at the start, they used to send poems. They used to send very long messages. So that was a little bit too much for the supervisors. So we had to train them on essential communication. So yeah, it's a learning process.
So if Dr. Kiara is ever in this side of the world, we'd definitely like to meet you in person. And so I think there are a lot of learnings we can share. Thank you so much.
Absolutely. Thank you.
Thank you. Thank you. So now it's time to say goodbye. From venue, would you please say goodbye and share your experience?
Okay, this is Dr. Moriyama, the chairperson of this medical working group. So thank you for everyone, all presenters and also chairs to have this wonderful sessions, and also appreciate sharing your knowledge and experiences with us. Thank you so much.
Thank you. I can see Lochan sir and Prasanth sir there. Okay, thank you. So, Michael Su.
Yes.
Yeah. Your few words about the experience of today's meeting and say
Yes.
goodbye. Yeah.
Yes. Okay. I think that it's my honor, and also I also learn a lot. Okay, from the other speakers. Okay, looking forward to future opportunity also.
Thank you.
Thank you.
Thank you. Thank you. Abhi camera on karo photo. Sanjay. Sanjay, are you there?
Yes, sir. Thank you, sir. Thank you for providing the opportunity to update the progress since the project is in the early stage. Just last few weeks back, we initiated the process, and we expect the community to come to. We are open to collaborate, and also we are eager to learn from the community, this vibrant community, and wish to share more progress next year. Thank you, Desa and team.
Thank you. Dr. Kiara.
Yes, thank you. As I said, I really enjoyed this conversation and learning about different projects. So I wish everyone good luck with the progress in their projects, and hopefully we can talk again as we progress. Thank you.
Thank you. Zatin.
Hi everyone. Thank you so much for the discussions and presentations for today. I learned a lot, and also I learned that we have many commonalities, and let's meet again to discuss what we have done so far in our project sooner or later. Thank you.
Thank you. Nirajan.
Yeah, thank you, everyone. It was a nice session. Thank you.
Dr. Patria.
Hi, everyone. Thank you so much for attending the session and for the engaging and very interesting discussions and sharing all of your respective projects as well. And as mentioned by Justine earlier, we hope to keep in touch with those interested as well to, collaborate further down the line. Thank you again.
Thank you. From Kyushu, Temdek. From Temdek, Kyushu. Dr. Dennis. Okay, so can you please take your camera on so that we can have a photograph? Gallery. Good. Okay, yeah, Dr. Dennis is also there. Final words? So smile, please. Yeah. Michael Shu, the camera. Yeah. Thank you. Now we'll have a photograph. Thank you very much. So hope to see you soon.
Thank you.
Bye. Yeah.